Good morning and welcome everyone to the Health and Adult Social Care Scrutiny panel. I'm Councillor Habiba Zaman that's going to be chairing the panel meeting, and could I ask panel members to introduce themselves, starting from Richard.
Richard Dunn, I'm the supporting officer.
Councillor Vivian Lees Hamilton, Murfield Ward.
Linky Dear Co-op team member of the panel.
Councillor Fazila Luna, panel member.
Do it now.
Councillor Leslie Warner, panel member.
Councillor Munro, panel member.
Dave Rigby, Co-op T on the panel.
Mike Doyle, Deputy Director of Nursing and Quality, South West Yorkshire Partnerships Trust.
Rebecca Elliott, Public Health Manager for Kirklees Council.
Stacey Appleyard, Health Watch Kirklees.
Thank you. We have apologies from Peter Bradshaw, Co-op T, and
David Flint.
David Flint,
Co-op T.
Co-op T as well. Can we move on to minutes of the previous two meetings held on the 15th of October, firstly, and 12th of November? Do we have anybody that can move that?
Happy to move that as correct.
Thank you. Item number 2 is interests. Please declare any interests on any of the agenda items that we will be discussing this morning.
Linky Day, I'd just like to declare that I'm a Health Watch volunteer, because often work that Health Watch has done is mentioned during the course of our meetings, and also that I am a volunteer member of the Kirklees Suicide Prevention and Self-Harm Prevention Action Group. Thank you.
Okay, this meeting is being held in public and it is being webcast. Is there any deputations or petitions?
No, I've not received yet.
Thank you. Any questions for from the public?
No, I'm aware of.
Okay, can we move on to the suicide prevention report?
Yep, so we came to Scrutiny panel last year and gave an update on some of the work that was happening around suicide prevention then, and I was asked again to come and give an update this year on 4 particular areas of the suicide prevention activity that's taking place. So I'm sort of assuming that you've read the paper. Just before we sort of go into the paper, it would just be probably worth me saying that obviously this paper has been pulled together through sort of multi-agency partners, really. So I'm here sort of speaking on behalf of lots of different people that have helped me put this paper together. So hopefully I'll be able to answer all your questions. So do you want me to go through each item individually, or do you want to just go through any particular points of queries or questions that you may have?
The panel have a number of questions, and we can go straight into the questions. Yeah, do you want to?
Morning. Got a question, just a little bit more information on paragraph 1.2 of the report. It talks about the development of a high-risk decision support tool for primary care. I just wondered if you could say a little bit more about what that is. Yeah. Thanks.
Yep, so primary care is one of the areas that we want to try and improve our suicide prevention approach to, really. We know from previous suicide audits that a significant number of people will attend primary care before they go on to take their own life. What they go to the GP to talk about, we don't know, but we can see when we look at our suicide audits that there may be frequent visits that take place. So one of the areas that we wanted to improve upon was primary care, and a colleague at Huddersfield University, who's also done some previous work with Mike at Swift, got in touch to say that he developed this model around an automated suicide risk assessment tool And it's really not to replace the GP's role at all. It's about trying to make it easier to find who on their records may be at risk of suicide. And the way that his model is put together is based on lots of sort of demographic factors. So it doesn't mean that that person is going to take their own life. It just means that they may have significant risk factors for suicide. So we're trying to help the GP find who that person might be. So it's to try and facilitate and inform a conversation rather than make it. It's not trying to say this person is going to take their own life. It's meant to try and enhance the conversation and make it easier to bring the subject up, really. So that's what the tool is intended to do. It's been trialled in secondary care, I believe, with good results. So the professor is now wanting to get a handful of GP practices across Kirklees that are willing to sort of trial it and see what it shows us, really. So that's the kind of stage that we're at. He has, as it says in the paper, he has been to the clinical strategy group with the CCGs to inform them a little bit further, and generally it was very well supported. A few points of clarification that they were after, which he's now working on, but generally in the main it was well supported.
Yeah, sorry, just to echo what Rebecca said there, it is very promising. There's still some way to go, I think, but the key to it is learning lessons from incidents where people have taken their own life, and that will then help clinicians and GPs in this case make decisions about future care and treatment.
Right. Okay, thank you very much for that. I'd just like to ask in relation to 1.8 and the improvement to enable Pathfinder support workers to provide advice, training and support for up to 600 men in the area. Is that across the whole of West Yorkshire and Harrogate? And in light of the fact that there's been a sharp rise in suicides, and apparently I went to the launch on Friday, and it transpired there have been 56 deaths from suicide in Huddersfield alone in the last year, or 2017, 2018. Is that enough to be able to deal with 600 men across the whole of our area? And the other question is, have those support workers been appointed yet? Thank you.
Yes, we bid for some funding last year to develop a Pathfinder approach to working with men, because they were seen as the target population as a priority. So we received the funding probably around August 2018, and we've appointed to the Pathfinder development worker roles. We're working very closely with the voluntary sector, in particular State of Mind, because they've got an evidence-based approach for engaging men. And they use a sporting metaphor. Initially, they used a rugby league metaphor, and that was really successful in engaging men to seek the support they need. It's not. It's quite a complex offer in terms of what people will need, which is why we're looking at a Pathfinder approach, because different people will need different support. So it could be from initial emotional support to specialised counselling, or indeed for inpatient care. So that's why we've used a Pathfinder approach to match the interventions with the needs of men. But yes, in fact, the second Pathfinder development worker started yesterday, so it's up and running, and they're doing a lot of scoping at the moment, and we're hoping to start the actual the groups that we've referenced here from March.
Oh, thank you very much. Thank you.
Where are the offices based?
We host the initiatives for West Yorkshire and Harrogate in Wakefield, in Swift, but they will be based all over the area from within the 6 boroughs. There's obviously Wakefield, Kirklees, Calderdale, Bradford, Leeds, and Harrogate.
Can I just come in with terminology here? Pathfinder, a relative newbie. I'm also governor on the trust, so languages coming at me. You say you're experimenting with a Pathfinder approach. I mean, can you actually explain how you say there's one person? What does that actually mean? And are they mainly looking at evidence and data to see, or are they actually attempting to outreach in the community? How does it work?
Yeah, they're actually doing both, but primarily it is to outreach and engage men in the first instance, because we know that the vast majority of suicides take place in populations where the people have not had any contact with mental health services. So it's trying to engage people more effectively, more successfully, and in particular men. And we know that men are less likely to engage with mainstream health and mental health services.
Could I just add to that? One of the Pathfinder workers, for example, has already been out to the Kirklees area and spent time with our suicide prevention action group as well, and had a separate meeting with myself to really try and understand what's happening in Kirklees, what is available for men. So it's going to be a really, really useful role, because actually she's doing the scoping that I think we all wish we had the time to do, and she's doing that across the whole of West Yorkshire and Harrogate as well. So I think once, it is like a bit of a phased approach at the moment, isn't it? But once she's got that information, it will be really useful for us locally as well to have that.
Okay, I mean, the other thing I would add as well, I mean, we're mainly doing Kirklees, but from personal experience of living in Hebden Bridge, where sadly it isn't just the middle, there's quite a disproportionate number of young males have taken their life, 3 of which I know of in the last 5 years. And so it's addressing those. I mean, some could possibly be drug-related, but in 2 cases they definitely aren't that I know of. It's this age-old thing, service provision and counselling and all those things and one of the things that concerns me at the moment, I do understand that bits of money have been put here and there, but it feels a bit on the outside looking in as it's very piecemeal. So even through our hub, we hear there's X thousand to spend and there's this bit and there's pockets there. But it's that bringing it all together and feeling that whether it's the doctor in the surgery is up to speed. So anecdotally, which I'm probably not meant to do here, but my daughter, who was going to do medical training, but her prime interest is medical health, realised the doctor's got 10 minutes. And in majority of cases, they're going to give them antidepressants. And they're not a solution to the underlying issues. And I'm desperately concerned about this 2-year waiting list and that's not our issue at the moment, but it is linked to it. So, how are we going to pull together the funding to really deliver counselling that not just the men need, but young people who are, many lost?
Yeah, I absolutely agree with what you're saying, and it is a frustration. One of the things that we try and do through the Suicide Prevention Action Group, and we mentioned this at the launch of the Suicide Bereavement Service last week, is that we're trying to raise the profile of the group all the time, because we are aware, and I'm aware obviously, that lots of different conversations are going on, and I'm trying to create a forum where all dialogue takes place so that we are all aware of what's happening and what's going on and where there might be gaps and where services are struggling. And as Mike touched upon, we don't want to just focus on services, because the people that are at risk aren't always accessing services, and in the main it's people that we're not aware of and they're not in touch with anybody. So we have to take a more of a community place-based approach and make suicide prevention everybody's business. And by doing that, people are still scared of talking about suicide, and we've got to try and assure people and get over that actually by me saying make suicide prevention everybody's business, what I mean by that is you don't have to be an expert. And that's one of our aspirations as a suicide prevention action group, that we're trying to have those sorts of conversations as well.
I can totally understand, and thank you for that. But one of the things that was really interesting for me is I attended your prevention day last week, and just 3 or 4 of your notices about services that were available, I photographed and decided to put them on social media, my social media page. Interesting, you put some flowers up, or I've grown these and get millions of likes. You put, January is a tough month for a lot of people. Great day organised by the council. These are some places you might, including the cafes that you flagged up. Only 3 people and no comments. So that it's probably the biggest issue is getting people to recognise that lots of people who might have a very nice talk with at the moment are feeling suicidal, and it's how we keep opening it up,
Yeah, just to say, in terms of making sure that there's a consistency across the region, we do have the West Yorkshire and Harrogate Integrated Care System have suicide prevention as one of their priorities, and we have a suicide prevention strategy just to do just that, to get that standardisation and consistency. The other thing in terms of engaging people into looking at getting to the support and help they need, we're also starting a campaign which was signed off last week, which will start again in March, and that will be a communication and media campaign, which will be hopefully be working on on social media and the internet to try and engage people in the services that they need.
Okay, thank you.
David?
Thanks, yes. My colleague mentioned the meeting the other day, I think it was the launch, and referred to some statistics about the increase in suicides more recently, but I couldn't actually see any reference to that in this report. It would be useful to have that kind of information in there, and also perhaps a comment on how you're responding to that increase.
Yes, it was me. I presented some statistics there, and there was there's been an increase in the number and rate of suicide across the UK of around about 12%. However, they believe that there is an increase in the number of suicides, but there's also been a change in the way that they register suicides. So we're not entirely sure about how big the increase is, because previously it had to be beyond reasonable doubt before a coroner would reach a conclusion of suicide. Now it's on the balance of probabilities. So that will inevitably increase the number. And the other problem we have is that we don't know if coroners are applying the same rules consistently. So we do think there has been an increase in suicide. We just not know how many. And in any case, I think there is definitely a priority within, certainly in mental health services, as I mentioned, in the West Yorkshire and Harrogate Integrated Care System, to really tackle this problem. And indeed, from April this year, we've been asked to bid for some additional funding, which will help us achieve some of our objectives.
And I think it was the last session you attended, there was a reference to some problems in terms of getting information from the coroner. Is that still an issue?
Thankfully not. We've overcome that barrier, and we are now undertaking our new suicide audit to cover the years 2016 to 2018. So one of our colleagues is doing that as we speak, doing it in combination with Calderdale and Bradford, because we share a coroner. So we expect to have results, I'm hoping definitely by a report by the end of March, I would say. And then we'll be really able to hone in on what the data for Kirklees is telling us, because this is overdue now. So we really want to get that rich information, and we'll use that information to inform what our priorities should be locally, and they will feed directly into a new suicide prevention action plan, which the multi-agency partnership will help write. So we'll do it together as a joint piece of work.
That's good to hear that, thank you. I have one question which is more kind of a little bit more information. On the Choose leaflet, the Northrop Hall leaflet, there's a reference to understanding attachment theory, and I wasn't quite sure what attachment theory was, only just briefly though. Thanks.
Yes, that's not my area of expertise professionally, but do hear what other colleagues are talking. Attachment theory is just that it's that sort of really early intervention, prevention, bonding theory, how we engage with our children, right from being pregnant and so we're talking about the sort of the first sort of days of life really are so important, and it's how we can sort of develop parents to become nurturing parents right from the outset. You know, it's harder for some than others, and we're really wanting to support that approach. So I can get you more detail on what's going on, but it's just really about really early intervention and prevention.
And would I be right in adding that it's very much an issue with adopted kids? The whole attachment theory is very much something that often can cause problems.
Again, I don't have any statistics to talk about that in further detail, but yes, I do believe that is the case. Yeah.
Can I just ask one question about the coroner? I mean, I don't know anything about coroners either, but you mentioned one coroner for Kirklees and Bradford. Is that normal, or does that mean we've got long waiting lists?
Yeah, it's Kirklees, Calderdale and Bradford that we share, so it's 3. Yes, yeah. I'm not sure about the waiting list, I'm afraid. Just from my professional point of view in terms of trying to get this audit done, the reason that we've tried to do it combined is because we've all sort of had similar difficulties doing an audit, so we felt that if we could try and do it together it would save time, and also it's standardising the approach that we take. So actually, even though we're looking at the Kirklees figures, we can actually then look at Calderdale and Bradford and learn from each other about what the differences are or similarities are between the areas as well.
It just strikes me, I mean, maybe I watch too many crime programmes on TV, but one coroner for that area strikes me as, are there vacancies? Are they not? I mean, it'd be an interesting question to just find out about, actually.
I think we've always had one that we've shared.
Just one?
Yeah. Zilla, did you want to come in?
It was a question of coroners.
All right, okay. Has that been answered satisfactorily? Okay. And I'd like to ask you on 1.9, page 15, you've Spirit in Mind. They've done some training. They've done 2 days training with faith leaders. How was that identified? And is there gaps in any other areas where you could deliver that training? And that was in 2018. So why has there not been a follow-up in 2019?
So is this to the training through Spirit in Mind? Yeah, that's ongoing. Sorry.
Yeah, that's a voluntary organisation, spiritual voluntary organisation that we work with to provide training, and that's ongoing. It hasn't stopped. That will be ongoing.
Not so much a question really, but just a few comments, if I may please. I think it's important to recognise that kind of behind the scenes in a way there's a lot of work going on to try and improve things throughout mental health services. In particular, we've got an increase in funding for the recovery colleges now, and also some more posts relating to dual diagnosis, which is also really important, and a brand new complex trauma personality disorder pathway as well within mental health services. And we heard at the last suicide prevention and self-harm prevention action group, actually it's the last but one meeting, from learning services, about new resources that are going into schools from a very early age, from September 2020, which is coming up very, very rapidly, helping young people to vocalise issues that they might be experiencing, whether that be at home or at school, and using appropriate language, and perhaps in a way calling a spade really about what's really happening rather than trying to disguise it as something else. And I'd really just like to echo what was said as well about all community members looking out for each other, whether it's families, friends, neighbours and colleagues, and taking advantage of the training that was just mentioned, whether it be mental health first aid or the assist training for suicide prevention, because it's amazing. And I think we've all a duty to do something about the problem that we've got relating to to suicide and attempt at suicides in our area, and any support that mental health services and the council can provide, which enables people to attend these training courses, which are actually quite expensive sometimes when you look at the cost of going, that would be welcomed. And so I suppose what we're looking at is, we're looking at people known to be at risk. We're looking at trying to identify people who are at risk but haven't yet been identified, but might have been if, for example, GPs have been more mindful. We're looking at early intervention and prevention, and we're looking at sustaining well-being and providing peer support, which delivered appropriately is just the best support you can get, really, from people who understand what it's like to walk along that path. So I really just wanted to highlight those things, and thank you for the time to do that, because I think it's important that we see ourselves as a community team, and just make people fully aware of what is ongoing at the moment to try and tackle this tragic problem. Thank you very much.
Can I just add to that as well, which that was really helpful. There is also the issue as an ex-teacher. Clearly, change has happened, and there is much less personal social education than there used to be. And in some cases, schools, in order to maximise the amount of time for the academics, have been cutting out even assemblies, or, I mean, they have to do a compulsory one. Is there an opportunity for the council or the group to be doing things to work with schools at a level other than a little notice, we're here if you need me? Because it feels like it's so important that it needs to be addressed by each class, by each form, a rolling programme that the council can run. Now, I know it's more difficult with academies these days, but I just wondered if that's on the plan.
The information that Lynn referred to was the PSHE statutory lesson plans that will be coming in from this September. So this is a really great step forward, that it will now become statutory for primary and secondary schools to have these lessons, and they've lesson plans have been written, and we had privy to see them, didn't we, at the Suicide Prevention Action Group meeting, and so we got to see examples of lesson plans from like year 1 to year 6. So starting from next year, a child entering into year 1, by the time they leave primary school, they've had 6 years worth of sort of wellbeing conversations, dedicated time, which can only be a really good thing before they transition to high school as well. So, the lesson plans are there to help teachers. Some teachers, I think they, from what we were told at the meeting, teachers can just stick to the lesson plan, or if they feel a little bit more confident or they've got experience in that area, then they may want to tweak them slightly. But for teachers who might be teaching it for the first time, they can just stick to the lesson plan. It's all there for them. So it's a really fantastic resource.
Is there any training being done for teachers?
I'm not aware of training, but there are early adopter schools that are doing these now. So that's training in a way, I suppose, because they'll be almost testing them and getting some feedback from those early adopter schools, but I don't know the answer for definite about training, I'm afraid.
I mean, the only reason I ask that is I know from much experience, those of us who are fairly touchy, socially English type teachers, we're fine with it. But no disrespect to mathematicians and scientists, it's not usually their comfort zone. And there is a danger that if that's being delivered by form teachers or whatever, then, it could be very patchy delivery.
Yeah, no, absolutely, I would agree with that. But I can get back to you on whether there will be training, because I'm not sure, to be honest.
Can I bring Health Watch in and request them to make any comments on what you've been hearing?
Yeah. Just the resources that are available to schools, are they available for parents at all? So I know that from a personal point of view, self-harm in middle school areas in Wakefield, for example, is quite high. And I'm just wondering, that's probably something that parents should really have access to, so that they can do that work at home as well, so it starts earlier. I don't know if that's something that could be.
I believe some of the early adopter schools are now engaging with parents to say we are an early adopter school to this approach. If parents want to come in and see what it is we're going to be discussing, then we welcome that. In terms of sort of secondary school, the Northorpe Hall offer, which you have sight of a leaflet here, they offer parent workshops for all different sorts of topics, including self-harm. So there are ways of engaging with parents through Northorpe, and your child doesn't have to be accessing a service to get that information, so that's good. Also in the report you will have seen that we're also working on some self-harm resources locally, one aimed at children and young people and one aimed at adults, and basically that's to try and take a similar approach to the sort of suicide prevention approach really, in that we're trying to encourage people not to be scared about having a conversation. So we have been engaging with students at Huddersfield New College to talk about language and, you know, how do young people talk about these things these days, and using that language in the resources as well. So we're trying to sort of, you know, again, get over that stigma in a way, to encourage people to open up earlier about things that they might be experiencing and worrying about.
That's great, thank you. Just one other comment really. We're, as Health Watch, are really keen to help in any way that we possibly can. I know that we've offered some help in regards to engagement of people who have attempted suicide. So obviously that door's still open. If you want to have a conversation about it, that'd be great.
Yeah, thank you. I will be getting back to you on that.
And just in reference to the training, and obviously places like Northorpe Hall offering it, at a hub meeting last week, what was really obvious is that some schools, particularly the primary schools, are keen to take this up, but it's the usual thing of releasing staff. And one of the things we've suggested that is a possibility for some of the money that's been allocated for mental health is that we could use that to, you know, provide some support, you know, staff support, so that could be delivered. But as always with everything, it's these little tiny bits, isn't it? Sorry, I'm talking too much.
Yes, sorry, I was just going to say, yes, I do appreciate it can feel a bit piecemeal sometimes, but I know one of the education links worker at Northorpe, one of her roles is about trying to work with schools to take a whole school approach, so looking at do they have a wellbeing policy in place. So there's almost like a whole school approach, and then additional top-ons that we can do if a school has a particular concern about a particular issue. So I appreciate it can feel like that sometimes, but we are trying to get better at that. So that, you know, it's not just something that we do when a problem's identified, it's almost just something that we do all the time in terms of our approach to wellbeing.
Is there any further comments or questions? Okay. Can I thank you for your input into this report? I mean, suicide is quite a complex problem, and it does require commitment from a wide variety of partners. Can I recommend that we acknowledge the report and we report back on the success of the support workers that you've appointed? And I'd be particularly interested to see how they've been able to link with some of the you know, attempted individuals that may have attempted suicide, and what the success rate has been on that. Whether, you know, it's been a positive impact, whether you've been able to prevent suicide. And also in terms of your school's work, you know, it'd be good to get an update on the success of that, and again, you know, whether suicide has been reduced as a result of some of the preventative work that you've been doing. Is that okay? Thank you very much for attending.
Thank you.
Thank you.
thank you for attending this morning. We will listen to your presentation and ask you questions as we go along. But before we do that, we'll introduce ourselves. I'm Councillor Habib Zaman. I'm the chair of this scrutiny panel.
Richard Dunn, I'm the supporting officer.
Councillor Vivian Lees-Hamilton.
Link Eady, a co-op T on the panel.
Councillor Fazila Luna, a panel member.
Councillor Leslie Warner, panel member.
Councillor Alice Munro, panel member.
Dave Rigby, co-op T on the panel.
Good morning, I'm John McSorley, I'm Head of Operations for West Yorkshire, for Yorkshire Ambulance Service.
Good morning, my name's Nick Smith, I'm the Director of Operations for the Yorkshire Ambulance Service.
Morning, Martin Percy, Head of Contracting for Greater Huddersfield, North Kirklees, CCGs.
Stacey Appleyard, Health Watch Kirklees.
Thank you for that. We are live on webcast and we do have the press in the room as well. We will move on to listening to your presentation, and like I said, we will ask panel members to stop in between and ask you questions rather than listening to the whole presentation. And then, is that okay? Yeah. Okay, thank you.
Yeah, just flick to the presentation slide. No, we'll go straight to... Yeah, please. So I just thought it'd be useful to give a bit of background in terms of the response standards that we're now contracted for. So there's been a change back in 2017. So the ambulance response programme was introduced nationally. Main objectives of the ambulance response programme was that we could prioritise the sickest patients to ensure the fastest response time and improve patient experience and outcome. We do that for the most serious calls by identifying key words from the caller, and it allows us to identify life-threatening calls really, really quickly and to send a response. And they're measured and benchmarked through the ambulance quality clinical indicators, and they're in the pre-packed slides. It also allowed us, as a trust and nationally, to drive clinical and operational efficient behaviours, so a patient gets the response they need the first time and in a clinically appropriate time frame. So that allowed us to more time to triage the call, so that allows calls to be placed in Cat 1, Cat 2, Cat 3, Cat 4 calls, making sure they are getting the most appropriate response. That could be an ambulance responding on scene, or it could be an RRV, a rapid response vehicle, or it could be one of our healthcare professionals in our emergency care centre, where the calls come in. We can actually provide advice over the telephone. So on some occasions we don't actually respond. We're able to treat those patients and signpost them to appropriate healthcare providers. This allows us to ensure the correct level of resource is dispatched, so that can include the air ambulance, our specialist heart team, so they're the hazardous areas response team. It allows us to identify suitable incidents for specialist paramedics to go to, so they can attend those patients and with their extended skills can actually keep them at home. And again, like I said before, we're able to do telephone assessment. So just go to the next slide, please. So very busy slide, I'll just try and talk you through it as succinctly as possible. So there are a number of routes into our emergency operations centre. There's NHS 111, there's healthcare professionals, so doctors out in the community, in acute trust, other 999 partners and hospitals, like I said, and patients themselves or relatives or friends of patients can make calls. So these calls can be handled by a variety of different handlers within the emergency care centre. So we've got the 999 routing avenue and we've got the non-emergency call avenue. So within our EOC we have obviously 999 call handlers, but we also have clinical advisors and we have a health desk as well with a paramedic on there. Calls are then dispatched to the 999 dispatchers, so sending rapid response vehicles and double crewed ambulances out. But also we have low acuity dispatchers, so sending low acuity crews out to patients that don't need that immediate response. And we also have health urgent care practitioners out in our communities. Calls are then passed to the responders, and they can respond, like I say, in cars, via specialist responders, but we also have community first responders as well, so we have some willing volunteers that are really helpful and want to help the community, and we dispatch those as well. Next slide, please. So a little bit more detail on the standards that have been applied through our contracting. So we have a mean standard for each category, and we also have a 90th percentile standard. So Cat 1, we have a 7-minute and a 15-minute respectively. Cat 2 is 80 minutes and 40 minutes respectively. Cat 3, 60 minutes and 120 minutes respectively. And Cat 4 is 180 minute 90th. As a result of these standards that have been applied, every call counts. So if there's a delay with one particular incident, it actually affects the mean. So any response time over the 7 minute for a Cat 1, for example, would drag the mean up. So it's really important that we resource appropriately. The new standards, like I said before, they allow us a lot more time within our emergency care centre to triage the calls, whereas before it was the call would come in and we'll dispatch a resource. But now we can actually spend a bit more time with the caller and decide what's the most appropriate response for them. Next slide, please.
John.
Yeah, sorry.
I'd just like to add in there, the change to ARP around the mean means that it measures the really outliers now. So in the past, when you were measuring response times for ambulances, the way that was recorded before was by having really long response times, the odd call didn't make a difference because based on the majority. Now by having the mean, it actually makes sure that those, if we have an extended response time in a category, it's reflected within the performance figures as well. That was quite a significant change when we changed to ARP.
Thank you, Nick.
Sorry, can I just interrupt? Can you just clarify that again? I do apologise. It just...
Yeah, so, sorry, before, the way that the change in the response time targets to the new categories, which means we get measured on the mean, which means that outlying, when we have really long outliers, response times, that now affects how we're performed and how we're measured. Whereas previously, it didn't have that much impact. Now it has a significant impact on the way that we're measured. So that means what that provides is more of an equity across the service. So it was put in place to prevent organised ambulance services bringing all their ambulances into urban centres where you had lots of activity at the expense of rural areas. That isn't the case anymore. This makes sure that if you have extended response times in rural areas, it impacts on your figures anyway. So it was a significant positive change from the Department of Health on that. Does that?
Can we have clarification? My maths isn't great. For example, in the ward I live in, if we take that one of the more outlying areas up on the hills above Marsden,
yeah.
And if you got, let's say, 5 calls from that area in a week, that's going to affect your response times.
5 calls would have a marginal impact on that, but for that particular area, it would do. If you had an extended response time, taking the category 1s where 90% of calls have to be responded to within 15 minutes, if you had a call that had taken probably 2 hours to get there, then that would have an impact on the figure, the mean response time across that area.
So you think this new way of reporting it is a more fair reflection?
Absolutely. Yeah,
okay.
It was put into place. In the past, some ambulance service potentially would have been, you could do game playing, you could actually bring all your vehicles into an urban area, into Leeds and Bradford, and more calls, get performance. Now there's no benefit in doing that now because you get measured across the all areas.
Yeah, that's it. Yeah. Can I add from a commissioning point of view? It's a lot easier now. Before the target was as long as you met 75% of calls within the 8-minute target, then you'd met the contractual requirement. With this, because everything's included, then it's a lot clearer to see how close you are to actually delivering that 7 minutes. So you could actually have quite a long tail, what we call a tail of performance, i.e. what was the time for the last person to be seen. That, with the mean calculation, it's a lot easier because it condenses the target into the 7 minutes.
So this is just to demonstrate our ambulance response programme journey and how we've measured against the standards. So back in sort of late 2017, early 2018, the Trust found it very challenging to meet the Cat 1 mean standard. However, as we've changed the way we resource our staff and increased the number of ambulances and the number of staff, we've seen an improvement as time's progressed. Next slide, please. So for the Cat 2 performance, again, very, very challenging initially. However, for the mean, we've got closer and closer to that standard as we hit March 2019, and improvements have been seen for both the mean and the 90th as well on Cat 2.
Question on the figures, because it only goes up to March 19, so that's a year ago. Be interesting to know how the trend has been since then.
Yeah, so we've just got on the sheet here. Just in terms of the trust as a whole, for our year-to-date figure since 2019, so Cat 1, 7 minutes and 6 seconds. So we had a very challenging December, increasing demand, a lot of pressure, not within just YAS, but also the health economy as a whole. So that sort of stretched that figure there. The 90th was 12 minutes and 20, so that's a green for our Cat 1 90th. Cat 2, 20 minutes and 33 seconds, and the 90th was 42 and 46 seconds. Did you want to interject?
Yeah, so from April 2019, I'm sure the commissioners know this, again, we continue to invest and to recruit people, and our performance has improved every single month until in September, August and September, we made every single national standard. Now, just John's point there around the pressures in the system, in October, November, December, we've seen some significant pressures, as all the NHS has seen, and therefore we didn't meet the Category 2 response time, Category 1 within there. However, John was probably going to point out, but in January so far, the pressures have eased for the ambulance service, and now we're meeting all the national standards again month to date. So we've had a very challenging period of 3 months, but prior to that we were hitting performance improvement every time and with the standards for August to September.
Just as a follow-up to that, would it be possible in the future to have, is it possible to have a graph that shows both the response time and the demand on one graph so you can actually see?
Yeah, we can do that for next time we come.
That'd be quite useful, yeah?
Yeah,
thanks.
Can I just ask you
Sorry.
on that? What are your implications if you don't meet the standard targets that are being set?
Within the contract that the ambulance service holds, given that it's commissioned on a regional basis, then there are a number of targets. And it's fair to say that then there's a discussion about how best to apply any penalties associated with targets. Given the fact that we're still operating within the ARP pilot type environment, and some of the targets are still being formed to see whether or not they're doing what they should do, then I think most of the decisions around any penalties is the wrong word, but sanctions that might be applied under the contract are reinvested to make sure we then focus on the bits that need to be improved.
Sorry, I don't know if we're meant to be asking questions as this goes on, but it's okay if that's all right with you, Chair. It's actually my question. One of my questions is about your service on Sundays. Do you have fewer staff operating those ambulances on Sundays? Because I have a case, or had a case whereby a resident was knocked off his bike at Combe Bridge. So I'm not sure which HD, where that will be in HD, but it's in HD, one of them. And The police arrived at the scene. They called his wife and told her to go up to the infirmary. He'd actually got a ruptured spleen, and no ambulance came. There was no ambulance available, and in the end, a private ambulance was flagged down or stopped at the scene of the accident, and actually took him to hospital. And it was, if that hadn't have happened, if he'd been an hour later, he would have lost his life. It was within an hour of his life. So I just wondered what your Sunday service is like. Thank you.
Okay, obviously I don't know the detail of that incident, but generally what we do, previously, I mean, I've been ambulance for lots and lots of years, and before we would have a rota, and it would depend on, the rota would dictate how many staff we had out at any one time. It's a lot more sophisticated now in that what we look at last three years' demand, and we use a model to forecast what our demand's going to be by day of the week, by hour of the day. And what we do then is we roster, we bring crews in and use overtime and existing staff to meet that demand. So we're constantly working towards that. So in answer to your question around do we have less staff on a Sunday, we don't plan to have less staff on it. We plan to have enough staff on to meet the demand, and we're very, very good, very close to, we're usually within like 1% of what we anticipate demand's going to be, compared to what hours we put out in order to meet that. So we're very good at that. Unfortunately, there is times when we do, for a number of reasons, not as much in the Huddersfield area, Kirklees area, but in some areas of Yorkshire where, due to outside pressure such as handover delays at hospitals, then potentially that can impact on our ability to respond to calls, because we plan for a number of handover delays. However, if that exceeds that or demand gets higher than what we expected to do, then that can be in a position where we necessarily don't have enough vehicles in the right place at the right time.
Can I just therefore ask, the word private ambulance, I'm seeing more around than they used to. How often do you use them, and are they sort of coming in by the back door, or?
Okay. I can assure you that the Yorkshire Ambulance Service does not use, for A&E services, we don't use private providers to do that. We use some private providers to do inter-hospital transfers in certain parts of Yorkshire, but our 999 service, unlike the vast majority of ambulance services across the UK, we don't use private providers to do that work. And I don't know, John, was it a few years ago? Probably the last time was a few years ago when we did that.
3 or 4 years ago.
But now with the investment we've had from the commissioners in to meet ARP, then we've recruited lots and lots of staff, we've purchased new vehicles, and one of the slides, perfect, that's the one, yeah. Yeah.
Ahead of you.
Yeah, but we don't use private providers, and that's why I find the incident that you mentioned quite interesting.
Sorry, in this particular accident, they'd actually gone over an hour and no ambulance had arrived, and his wife was actually waiting at the hospital.
Yeah.
It was just looked at, this private ambulance saw the accident and stopped.
Yeah.
And it was down to sheer luck that his life was saved, in actual fact.
So in fact, the private ambulances we see around occasionally, are they more likely to be do with private healthcare?
Yeah, potentially I'm not quite sure what the acute trusts, the hospital trusts, if they may commission, not for emergency calls, because that's our responsibility, but we commission a small number of private providers for inter-hospital transfers. I'm not quite sure, John, whether or not the Kirklees, Calderdale actually commission their own resource.
Yeah, it may be that some of the hospital-to-home traffic is commissioned through acute hospitals to private ambulances and taxi if it's clinically appropriate to ensure that the patient can be discharged at an appropriate time and get home. So it is conceivable that a lot of the private ambulances that you see are on that sort of activity.
I mean, I think it would just be quite useful to get some figures about use of private ambulances at some point, because, you know, one wants to keep everything in-house if one can.
Yeah, can I just answer that? I mean, clearly there are a number of rules that the NHS has in terms of no, press the button. So, I'm still on. Sorry. Are you switching yours off? Yeah. That you know, technically we're not allowed to discriminate between the ownership of the provider, if you like. But I think certainly in West Yorkshire, for example, the patient transport service is held by Yaz. But there will be within West Yorkshire elements of some patient transport that is commissioned directly with individual firms.
Just on the figures while we're on, you've indicated you have over 2,700 emergency calls per day. How many of them are genuine blue light calls?
I'll give you a Greater Huddersfield and North Kirklees perspective, because clearly from a commissioning point of view we monitor activity. So in month 8, I think that would be November, so apologies, there's a bit of a lag because of the reporting and validation, but in November, Greater Huddersfield, there were 3,431 urgent emergency calls, and in North Kirklees there were 2,979, and of those, probably the ones that you'd classify as the urgent emergency ones, i.e. the ones that they arrive on scene and then have to convey to hospital, then of that there were 2,092 in Greater Huddersfield and 1,816 in North Kirklees. So about 2/3 of the calls result in a conveyance to hospital.
So this slide just demonstrates how much support we've had from our commissioners in terms of our staff growth. So back in 2016, we started off with 821 clinical support staff and 881 paramedics, and that's grown year on year, which has allowed us to ensure that we can support our remodelling. So we now have less RRVs, speaking ambulance terminology, less cars, and now we have more double crewed ambulances, and that's because a bigger pot of patients fall into the category 2 section, and they generally need transport into hospital. So in the old money we did use response cars to get to patients, treat them effectively. However, because of the way the calls have changed and the categorisation, a lot more patients need conveying under these new standards. So that's how we changed our model, and it was supported by our commissioners. Just in terms of how we retain staff as well, so obviously we recruit staff but retaining them, so we look at various different rotational models. So we work with local GPs in terms of supporting their rotations, and also in urgent treatment centres, so our staff go in there for so many weeks and then rotate back out, and that just helps to keep their retention as we move forward. Okay, thank you.
Sorry, just a question. How many open vacancies do we have at the moment in that section?
Sorry?
So we're looking for, we're always wanting more staff.
Yeah.
So how many open vacancies, or what kind of, because obviously the number of since 2016 to now, obviously, yes, we have staffing has increased, but how many open vacancies are we still short of, kind of thing?
Okay, the planned recruitment for this year, we're 8 people short compared to what we expected to do at the beginning of the year, to where we're going to plan to outturn, which I think is quite an achievement when we look at how many people we've recruited, over 250, 300 people. A lot of that's turnover, obviously people retiring and so on within there. So we're very close to what our figure is. What we do though, we always keep between 5 and 10% of our available staffing budget to use overtime. That allows us then to meet the peaks and the troughs within our demand. If we had the same number of staff on all the time on every single day, then we'd have time when we didn't have enough crews on, and times when we'd have probably too many. So that's back to your point around on a Sunday.
Can I just, I'm just going to add, in terms of retention of staff, I mean, personally, I cannot think of any other job I have more admiration for in terms of paramedics, frontline, ambulance drivers, dealing with our traffic, dealing with a whole range of acute services. So it's clearly an incredibly stressful job.
It is, yeah.
So in terms of well-being, is there a good well-being support for the staff?
Yeah, we've invested significantly in our occupational health services. So staff will have ability to ring 24 hours a day to a support line to do that. I mean, John, you probably answer this probably better than what I can along that. We've introduced peer support as well. So one of the things that's a consequence of getting busier and busier is that our crews have less tied down time, whereas previously would have gone back to ambulance stations and they would have probably had an opportunity to talk in the mess rooms with the colleagues. That doesn't happen now. We've always got work outstanding. So the welfare thing is really important. So we have invested in there, but we recognise that we can never do enough around support. And it's not just our operational staff, it's our staff who work in our control centre who take the 999 calls. They're usually the lower paid staff than what frontline staff are. It's a very stressful job. It's constantly, there's calls waiting to be answered and they don't know what the next call is going to be. So again, we're trying to invest and put support in for the back office people, the non-frontline staff as well to do that, because it is a very, very stressful job.
So if at the end of a difficult accident, or if at the end of some really stressful calls, is there always online counselling available at the end of a shift, so that people need to discuss something traumatic they've seen or had a really hard time listening to?
We have clinical supervisors on duty 24/7. So the first port of call for our staff to go seek support is through those individuals. So they can make a decision to stand the crew down, so take them off responding for however long, so it might take them back to the station, just have a debrief in terms of that particular incident, if there's any sort of follow-up paperwork that needs to be done, but also signpost them direct to our employee assistants in terms of getting that support online and making that telephone call as well if they wanted to speak to somebody sooner rather than later. So there's various mechanisms of support, but the initial port of call would be their clinical supervisor.
Thank you. So on the whole, it would be unusual to be losing, say, paramedics or ambulance drivers because the stress just feels too much. You know, we can't offload enough, you know. I mean, I have problems sleeping sometimes just from stuff I hear in the community, and I'm not dealing with life and death matters, you know.
I mean, what shy away from it is a very, very challenging job, and, you know, anxiety, stress is one of our significant areas that we look at in terms of sickness. So we do put this support in place in terms of making sure we've got a robust health provider in place that makes sure it's more reactive and more accessible so this staff can get early support.
John, just add to that as well, and part of the roles that John's explained there around some of we're now putting paramedics into our control centres and putting paramedics into GP surgeries and supporting that way. And we believe that's a way of actually taking people away from that front line for a while and rotating round. So that in itself may help reduce some of the stress. It's a bit more balanced rather than day after day constantly dealing with difficult calls.
Just going back to staff retention, we've now got a robust career framework in place. So we're using the apprenticeship scheme to support our staff through academic growth in terms of they're coming into the organisation as emergency care assistants, and they then can go on to the next role. And there is a clear journey and a structured approach about how you join the ambulance service on the A&E side from the emergency care assistant, progressing right through to paramedic and onwards. Just made that really clear and allowed staff to have that support. Okay. This slide here just demonstrates the amount of pressure of the organisation, and it reflects the rest of the health economy. 2015 we had around 51k jobs into the organisation. Over the years that has grown to 60,000. So that's why we've needed to change our modelling and change the number of staff that we have out responding and how we respond. We've also looked at hear and treat within the emergency operations centre, so we can actually provide that support to patients and not have to respond to every single patient that doesn't actually need a response or transport to hospital.
Are there any factors that you've analysed that can help explain when you get these rises like this?
There's an increase in the age of the population, so a lot more comorbidities. Patients therefore need a lot more wraparound care, so it's partly to do to that.
And presumably the general lack of social care, etc., is meaning more people end up needing help and transporting to hospital, whereas if we had more in the community, that would maybe have a lessening effect.
I think challenging social care and the rest of the health system impacts on the ambulance service, because if people can't access healthcare quickly, then the default is 999. It's always there, 24 hours, 7 days a week. So yeah, so there's times if pressure builds in certain parts of the system, then that consequences impacts on our demand.
You keep statistics of who mainly uses it, you know, I mean, are 50% of your calls from people over 65, for example? I mean, it just...
Yeah, we do. We record that in lots of... In fact, we have lots of data. Sometimes it's hard to pick out patterns from that information. But we are working with Public Health England around... This data can be fed into one central, and you can start to see patterns based on geographical areas, on deprivation, and there's lots of information there. And that's really something that we find quite exciting going back in the next few years, is for YAS, the ambulance service, to start to work with the rest of the health system to try and, can we pick patterns out, can we help, can we identify where we need to, rather than just sending... I think the days of actually just recruiting more ambulance staff, more ambulances, is probably gone. It's on looking at demand now. What can we do, interventions at an earlier stage, to prevent people actually needing to access the health system, or if they do, can we support them before it needs to take people to hospital?
So this comes back to the old communication thing as well, doesn't it? Like, I'm thinking of the Good Companions, an elderly group in Slowett. You know, having somebody come who would say, look, if you have a fall, if this, if that, you don't have to ring. There are these other places you could ring for support, you know. So there is maybe, as people like me become the oldies at the top end, you know, maybe that's something, because we are going to be swamped with it. Sorry.
From a commissioning point of view, you're right. I think a lot of our planning, it's a horrible term, but I suppose signposting people to appropriate other options is a key thread through developing the community service and the primary care service as well, in terms of development of primary care networks and people like social prescribers. And I say the horrible expression is self-care, which sort of is a bit of a misnomer, but what that means is people can have a greater reliance because they know a lot more about what they can do if they feel that they need to access services.
Could I just ask a question? In relation to the access to defibrillators in all our communities, are you finding that that's making a difference at all?
This is really one of the real success story around. There's a couple of angles. One around having community-based defibrillators in community. I mean, every week we're engaging more and more, and there's more support being put into place. House builders are now working with the ambulance service to put defibrillators in locations. Some councils, Barnsley, have invested a significant amount of money in actually putting public access defibrillators in place as well. So it is a real growing area. That's one part of it. The second part of it, I don't know if people are familiar, but with Restart a Heart, we do that once a year. We were one of the first organisations to really start that. And I think this year we trained over 40,000 15 to 16-year-olds in how to use CPR and an AED, which is absolutely, I mean, we were so proud of that, and we've won a lot of national awards around that. But that's not important. It's around actually, does it make a difference? And an example, I mean, on personal experience, my daughter went to school in York, and Restart a Heart went there about to train, and got defibrillator trained. About 3 weeks later, they were having a sports session, and a 16-year-old boy collapsed playing football. They went down to get the defibrillator, brought it up, did CPR, and is now perfectly normal. He's been walking around. If it hadn't been for that scheme, and hadn't been for the school investing in that, then there'd be a 16-year-old boy who would have died. And that's quite personal to where my daughter went to school.
So this slide just, I suppose, just don't it's a bit of a heat map in terms of where we're doing really well in terms of performance for Category 1 on the 7-minute standard, and then sort of the more challenging areas, I suppose, as you expect, up the different valleys in terms of Colne Valley, Dearne Valley and Home Valley. So for the most of the postcodes, we there or thereabouts in terms of the mean, but we do see that the valleys provide a bit more challenge because of the longer journey times. overall, in Kirklees, we see between 12 and 15 category 1s per day. Category 2, we see between 70 and 80. Obviously, there's a little bit of variability there.
Could I just come in here, Chair? And I just want to ask a question. I, for my sins, live in HD8, and I've noted that the response times there are the worst out of all the areas in Huddersfield. So I just wondered if you could explain why that is, because I just live 3 miles from the town centre, basically, but the response time is looking at the heat hotspots, 12 minutes. Almost 13 minutes. They're the highest response, the longest response times. And I just wondered if that's linked as well to what's the flow of ambulances? Are more ambulances being pulled out to other areas? Is that one of the causes? If you could just explain it, please. Thank you.
Yeah, I suppose in the past, when we've been understaffed, there's been a lot of resources pulled out of area. But as we've and continue to see an increase in staffing, we don't lose as many resources out of areas. However, there are occasions where we need to go to specialist centres. So if major trauma, for example, those patients, if they fit certain criteria, would go to a major trauma centre such as LGI. In terms of resources, they obviously start at stations and they do get pulled slightly to areas of demand, but they are returned where possible back into locality. And we try to use status plan management, so that's based on historical demand to look at keeping ambulances in certain key areas. So we generally use a mixture of roadside standby points and some facilitated standby points. So it's probably slightly related to that geographical area and demands getting pulled elsewhere, if that makes sense.
Sorry, just to come back to that, because I find that surprising with it being, it's not out in the rural area, it's on the edge of the rural area, but it's definitely urban. So it's very surprising that they've got the Fenny Bridge and Lepton have the longest, longest response times. I just wondered if there was another factor that's not evident.
Just something I just want to add to John as well is when we see increasing demand as well, when we're very, very busy, which we've seen in October, November, December, I don't explain July. However, when we see increasing demand, then when our vans become available, they usually become available at the hospital, whether that's in Halifax or whether that's at Huddersfield primarily. So when we're quieter, we're able to strategically place our vehicles and return them to station, all the places. When we're busy, we can't do that. So every activation is usually from the hospital. So that has an impact as well. So I'm not great with the geography of Huddersfield, but if every time we come available at Huddersfield HRI and been allocated, then 7 minutes to get to some of those areas is a challenge.
Okay, thank you.
Just follow that as well with very detailed response times. Clearly that's the point at which you pick the patient up, yeah? The treatment starts. Clearly there is, well, at least there's a perceived issue, as you can imagine, probably guess what I'm going to say, is the journeys then from the ambulance to the hospital. And with the changing policy that ambulances mainly go to Calderdale, the journey can be longer. I know road improvements have happened, and etc., and this does get mentioned quite a bit. But there is still a perception that, or there is a worry, actually, about being that further away from the hospital for when you have that heart attack or whatever. So I know in theory some will still be able to go to HRI and things like that. But, I just wonder if those figures about from when you collect somebody to arriving at the point where they're in hospital is a cause of concern.
So there are certain conditions that need to go to specialist centres because there are specialist consultants there, and it is the definitive place of care for a patient. So rather than us taking us to one particular hospital and then them having to have a secondary transfer, it makes more sense and is more timely overall for that patient to go to that specialist centre. While the patients on board, our paramedics are highly trained, so they're providing ongoing care for that patients. So we're supporting them through that journey, whether it's to the local hospital or slightly longer. So they are highly trained and they can monitor and provide pain relief for that particular patient's condition, if it's for a heart attack, for example.
No, I was just going to ask.
Yes. Apart from some sort of interim service reconfigurations, there hasn't been a change to HRI being designated as an ED receiving hospital. Right. So ambulances still go to Huddersfield. I think what does need to be clear is that, like my colleague said, that depending on the appropriateness of the treatment that's required, then that might determine the receiving hospital. So, for example, if you, God forbid, you get knocked over in Calderdale, then they'll drive past the hospital to get you to HRI, because that's where the trauma department is, so that you're being taken to the most appropriate place, not the nearest hospital. I think that's probably fair to say.
That's a big change. That's how it's changed for the past.
Yeah, just in regards to the response time graphs, can I ask why we haven't got any information about from any of the North Kirklees postcodes at all? We've only got HD1s and HD. We've only got Huddersfield. We've got nothing for North Kirklees, and obviously I understand this is for North Kirklees as well as Huddersfield. It just seems like everything becomes Huddersfield centric really, and nothing goes back to North Kirklees.
That's all that matters.
Well, it isn't.
Yeah, I can only apologise. That's the information I thought had been requested. But next time we will...
Specifically remember, because it was Liz as chair, and we definitely requested it last time as well.
Okay, I apologise, and we will rectify that for... Yeah, okay.
Actually,
in that case, it should have been in there first time.
Sorry, could I just ask one more question? It's in relation to Barnsley A&E, because for me, actually, from Fenny Bridge, it's going back to the point of response time, it's actually, it only takes, in a car just doing 30 to 40 miles an hour, half an hour to get to Barnsley A&E from Fenny Bridge. But presumably your ambulances are just going to the main A&E hospitals, Calderdale, is that... Or do they ever, actually go over the border as such and go to Barnsley? Because that's actually closer for people who live in Fenny Bridge.
I can answer. No, they are taken, I was going to say all over the place, but that's not quite the proper way to describe it. There are, as I say, links to that point that they're taken to the most appropriate place, and certainly from an acute provider point of view, there's a lot of communication that YAS get in terms of how the capacity of A&E receiving departments. So on some occasions it might be that they know that, rather than take them to Huddersfield, it's better to take them to Barnsley because they know that they can receive them there, as opposed to, a delay. But what we see as commissioners is all of the A&E activity, and invariably they are conveyed by YAS there, even across into the Lancashire borders there. So the south of the patch is fine because it's all part of the Yorkshire and Humber contract. So it's when you go across the border into Lancashire, because they're part of the northwest arrangements, and there has to be almost like a knock-for-knock arrangement. So some of the northwest ambulances, by definition, will come over into Yorkshire.
So here we're looking at the Category 2 response times. Just remind you, that's 18 minutes. Patients that fit in this category are those patients that fit in, had a stroke, heart attack and stabbing. So obviously they don't need an immediate response, but the sooner we get there, the better for the patient in terms of we can start that treatment. Specifically for stroke patients, we're really keen that our crews do an immediate assessment, start the treatment and get to the hospital as soon as possible. Whereas before, there's not been that sort of direction from the trust in terms of how quickly to get those patients treated and transported to hospital. So we've really been pushing that for some specific conditions. Obviously, early in the year, we sort of better performance, a bit more challenging as we've got into the busy period of 2019. Something else you want to add, Nick?
No, not really, John. Just with the Category 2 calls, and this is a double crewed ambulance majority of the time rather than a first responder on there. There's anything really to add towards that.
Okay, thank you. Excellent. So just in terms of how we work together with our partners and managing demand and performance, so we meet regularly as health partners through the A&E delivery boards. We also work closely at the acute trust with the ambulance handover A&E. So where there's pressure on particular days or period of the day, we'll send one of our clinical supervisors to work with our management team and just make sure we've got patient flow so our crews can hand patients over as quickly as possible and also come clear for the next patient that we need to respond to. And we try to take a system approach on this. So like I said, in terms of managing that demand as it comes in, we do a lot more hear and treat within our emergency operations centre, so we've put clinicians in there to do that. But also out in the community, we're developing more and more pathways as we move forward, so we can keep patients at home, or if they do need to go to acute trust, instead of going in through the front door, we can go direct to an acute admissions unit. So we're trying to develop all these different pathways across Yass and locally as well, so we don't basically block all the beds up in the emergency department.
Sorry, can I interrupt?
Sorry, of course.
Just in terms of your handover to A&E staff, how would you say that the relationships now is working out? Because obviously, over time, and I've had to go into A&E and obviously spoken to various people, you can see the Yass staff waiting to do the handovers, and there's a backlog. There seems to be a backlog, and obviously staffing and everything is a big thing again here. But how is that handover time being worked with now?
Yeah, generally it's well managed. Generally, it's well managed. We have systems in place in terms of we know when the crew arrives, so they have to press a button on a computer screen. We know that then they've got the 15 minutes to hand over to the triage nurse, and then they have to agree a handover time. So actually, we don't see that pressure this side of the West Yorkshire, where other places we do. You've probably seen it in the news where other acute trusts have a high number of ambulances sat outside the front door, but we're not seeing that locally.
And just from a Yorkshire perspective, across a wider rather than just Kirklees and West Yorkshire in particular is much better, quicker at patient handovers than other parts of Yorkshire. So I think success, it works really well within this area.
Start for that from a contractual point of view, because clearly the emphasis is on Yass, but the acutes also have a target in terms of facilitating hospital and ambulance handovers. So it's almost from a system approach, which means all partners are trying to resolve this. It's not just Yass's responsibility, also the acute hospital has to make sure they do their bit.
Next slide, please. Thank you. Nick touched on it earlier in terms of how we sort of predict our demand and how we match our resources. So we have a specific department that looks at that for us and trawls through the data, looking at seasonality, events, that type of thing, to make sure that we match our resources, whether that's double crewed ambulances or RRVs, to the demand that we're going to expect. In terms of our clinical quality care, we're working across the health system, so we're developing our specialist paramedics, both in urgent and critical care. We've talked about the rotational roles to keep our crews interested and keep them within the organisation. But also, there's a lot more growing our own, so we're working closely with the local universities and paramedics that are in training, so student paramedics will come to us and they'll do the placements within the organisation. That helps to retain them because they get to see the organisation, how it works, and see if their values match our values. If they do, then they're more than welcome to come. If not, it's a different discussion. And then I've talked about the apprentice scheme in terms of how we develop staff from emergency care assistants upwards.
Yes, thank you, Chair. I just want to ask, in terms of dealing with patients who've got a mental health condition, and it may be that perhaps they've self-harmed and need to be transported to hospital. And I'm just wondering what level of training the paramedic staff get in terms of mental ill health, and also whether the level of support that is currently available from mental health services is perceived to be adequate for staff who are out there doing the day job, please.
So first of all, we do have mental health nurses within our emergency operations centre. So before we even dispatch a call, they will be involved in the discussion with the patient to see what appropriate care they need. If we do need to attend and transport that patient, then our crews can ring in to the nurse, speak to the nurse to see what's the most appropriate route for them, because we all know that A&E isn't the best route for mental health patients. And we also have various different pathways across the organisation in terms of how we look after those mental health patients that don't need to go to ED. So it could be a simple cut on their arm that doesn't need much attention, so they get some more specialist mental health support. And if we keep them at home, that's even better for them, because going into A&E, it's not the best environment if you're having a bit of a crisis. So we try to give them that wraparound care.
Can I add? I think it's important to note that there's quite an emphasis over the next couple of years in terms of making sure that the services for mental health cases is actually fit for purpose. So there's quite a lot of investment in, for example, specific vehicles that are going to be used for conveyance. There's also quite a lot of investment within the mental health services that you'll start to see. Well, started this year, you'll start to see building over the next couple of years, and things like first point of contacts for crisis and those sorts of things. So the whole system being more joined up, so it's not just left to one of the partners within the system to deal with it, in that there'll be a consistent approach to people with that sort of issue.
And just to ask, please, in terms of the support in the call centre, is that available 24/7, or is it just certain times of day?
From a staff point of view, it's 24 hours a day, 7 days a week. From a support from our existing staff, the mental health nurse that we have in our EOC, they're getting scheduled against the demand that we see. So when we have significant increases in demand, which is usually on a Friday and Saturday night, we see a peak in demand. Then that's when we schedule the mental health nurse to be on duty then. We're in process of recruiting more as well, but it's a challenge area to recruit. And going forward, what we want to do is to work more, rather than actually putting an advert out and recruiting mental health nurse to work in the ambulance service, working a wider system. And again, we want to rotate our paramedics out into other areas of the NHS. Then what we're looking at doing the same with mental health nurses to make their role more attractive and just work together generally. But the mental health nurses within our control centre make a significant difference in Hear and Treat.
And just to ask as well, do you have a lot of interaction with the mental health liaison teams that are based in A&E in Calderdale and also in Huddersfield at HRI?
Certainly from a staff patient experience, that will happen when they go in and hand the patients over. So and make sure that patient's clinical history is handed over in a clear and concise manner, so that will happen at that point.
And just to ask a further question to that, do you find that there is generally someone available from the mental health liaison team at that point when it's appropriate to admit the person, or do you sometimes find that there is a delay in that availability?
I'd actually have a difficulty answering that question. That's a very patient one-by-one experience. I don't know. So sometimes it's probably very, very responsive. It'd be unfair of me to comment. I don't know.
The question I was asking was just, is there sometimes a delay in you being able to hand over the patient in A&E because there isn't anyone available with the mental health nursing background to accept them?
Sorry, I misunderstood the question. The triage nurse, if there's nobody else available, we would primarily speak to the triage nurse. So that continuity of care would then pass from YAS to the triage nurse and then on to the mental health. Does that answer your question? Sorry.
Thank you.
Okay.
This point of information, the paramedic degree programme, is there one in operation at Huddersfield?
The closest one is Bradford, so it's a 4-year programme.
It's Bradford.
It's a sandwich year. So they come out to YAS in year 3 and work on the ambulances for a full year as part of that sandwich programme. So it's really good, really supports them. So whereas before you do a full degree potentially and you then just come out operationally expect to work as paramedic, which, you know, it's quite a difficult role and you need to, you know, get some more experience. So Bradford's the nearest one currently. Just final slide from us. Just wanted to inform you about our own in-house development. So previously, when we were recording patients' details, it was on a big A3 pad, very complicated, and in terms of handing that patient over efficiently to ED, it's a manual handover. In terms of how it interacts with our records, quite challenging. So this has been developed by our own staff, our own IT department. It's been really well received. It's refined all the time, so different staff come up with different ideas, and there's a team working on it and adapting it, so it can, you know, it's the most comprehensive report that we have, and it's easy to hand over to the hospital, so it's done electronically, and you know, it's gone down really, really well. In terms of the other efficiency that we've put into place, so we have the ambulance vehicle preparation programme. So the clinicians used to come on duty and they would have to check their ambulance, so not from just a mechanical point of view, but make sure all the equipment was on board, that the defib was working, that the batteries were all charged up, that it was clean. Across Yass, we're rolling this programme out, so the ambulances are cleaned on a regular basis in terms of having a deep clean, but they're also checked at the end of the shift now, and there are special packs that are made ready to go to the ambulances, and the crews basically just come on duty, do their legal checks, and then they're ready to respond, whereas before potentially they weren't available to respond to all calls for like around about 20 minutes, but now they're ready to go once they've done the legal checks. So it's been a massive improvement, and we're rolling that out bit by bit across the trust.
And so if during the course of that particular shift for the Yass drivers and the personnel, if they needed to restock, would they need to go out of the area? Or because I think, was it in Leeds or somewhere before, or somewhere, can't remember, but I was still needing to have them to go out again and to restock. Sorry.
Okay. Yeah, so the nearest one at the moment is Huddersfield, is our AVP centre. There's generally enough stock on the ambulance to get you through a shift, unless you're having a very, very difficult, challenging day. But yeah, if you do need to go restock, you go back to base and you just get a new pack from the AVP team.
And in just the next question, just in the event, say the van the ambulance needed to be cleaned and sanitised and everything like that, how long would it be out of action for, or what would happen to the staff whilst they were waiting for it to be cleaned up?
Best case scenario, we've got a vehicle ready that's already prepared, so they could go down to the station. It's just a matter of taking their kit off and transferring it to the new vehicle and doing their legal checks. If we're having a challenging day in terms of vehicles, it would, when we could get that vehicle back to base if one's been repaired, for example. So it could have just gone in for a service, so we'd get that back as rapidly as possible through our management team.
Can I just ask as well about, we all know that there are times when there's lack of beds and possibly even lack of space in the emergency at the hospital. Do you ever have situations where ambulances are being held up and you can't unload the patients very often? I mean, which obviously takes quite a lot of ambulances out of action.
I think I said earlier, I think in this area that's very rare that happens. I mean, it can happen occasionally. However, other parts of Yorkshire and the UK, that is a significant problem. And I know over recent weeks there's been some areas of England where there's been up to 20 ambulances outside an ED department, but that doesn't happen, very rare that would happen within West Yorkshire, and especially rarely within Calderdale and Kirklees.
Thank you.
Can I bring Health Watch in?
Hey, thank you. Right at the beginning of the presentation, you mentioned that calls are triaged by keywords. Do you log the data of if somebody's said a certain keyword, but actually when responders arrive, that isn't actually the case, for example? So say somebody's said something, but so they might be triaged to have an urgent response. And when paramedics arrive, is that not actually the case? Just so that from a patient point of view, there's some learning around, being able to say, this is, some sort of learning that we can send out to patients, for example.
Yeah. The answer to the question is no. It has been no. It's been we get the first category of a call, and then we allocate what we think is appropriate resource, and then it would be when the crew got on scene, then they would then transport the patient to hospital. What we do now, we're able to, because of the electronic patient report form, is that at the end of the call, the crew themselves put in I forget the term, a working diagnosis, I think it is. And what we've been able to do now, from my IT point of view, is to link that with the original call that came through. And it's very early days, but what it allows us to do then is to understand which codes lead to which outcomes, because it has been I think it's a big frustration. We've been operational, we've been paramedics, and it is frustrating when you get a life-threatening call and you go through and you get on scene and then you realise that actually it's not quite what was made out to be. So we are able to pull that data together now, and this is only within the last few months to be able to do that. So it's quite exciting to be able to do that, and I think the next step then is to probably tie that back into what does that actually mean, and can we influence nationally around what the code set should be. It's a really interesting point you raised there.
Yeah, I think it's something that we as a Health Watch would like to look into further. You know, people experiencing, you know, traumatic things, actually saying these key words, actually get an ambulance to you quicker. You know, and we need to obviously make sure that it's appropriate and things like that. Just based on the outcomes that you were talking about, do you actually measure outcomes of patients once you've dropped them off at hospital, or is that your kind of job done?
Yeah, so we have various care bundles that we're contracted to deliver. So for a stroke, there's certain care bundles we need to deliver, but also for somebody having a heart attack, also our survival to discharge. So we may get some patients to hospital that they've had a cardiac arrest and we've been able to get a pulse back, so they've got return of spontaneous circulation by the time they get to the emergency department. But more importantly, it's those patients that we can actually get discharged from hospital. So the survival discharge, so we measure those as well. Does that answer your question?
Yeah, that's great, thank you. Yep.
Just add to that, I think what you'll see over the next 18 months, 2 years is a greater awareness of what somebody's pathway is through the urgent and emergency care pathway. So there's, for example, the development of a minimum data set which will capture all of the urgent activities. So if somebody presents at A&E, or somebody rings 111 who then eventually ends up in A&E or through the ambulance service, we'll be able to track the path and also the outcomes. And because some of the NHS, because the other thing to then mention is, I don't know if you're aware that YAS also operate NHS 111 in Yorkshire and Humber, which means that there's quite a lot of interconnectedness in terms of those emergency services. But what we'll start to see is, you know, whether or not interventions are effective and the outcomes, and we'll have a richer bit of information. The other thing I would add is that there's this concept called high intensity users. So, for example, if there are, excuse the expression, but repeat offenders that are continually calling the ambulances out, then it's likely that they will appear on a high intensity user register or list. And what the commissioners, with support of colleagues, will do is push that back to primary care to make sure their GP knows that, you know, that this is what's happening. So there's quite a bit of work in terms of that, which not necessarily is about the actual individual outcome of a call, but it's actually building to get a better picture of the people that are using the services.
That's great, thank you. And I have just one more question. The electronic patient record, is that just for yourselves? Obviously, on a Yorkshire basis, the LICRA record is being produced. Does that feed into that? Do they all talk to each other, all the systems? I'm just wondering if that's been thought about.
Yeah, absolutely. LICRA, we're heavily involved in the development of those developments and integrating with both from pulling information into our electronic patient record, which is important, and also then feeding information back out again. But LICRA is a real success story across Yorkshire, and we're heavily involved in that.
That's brilliant, thank you.
Can I just ask as well, in terms of what you were just saying about these, you use the word offenders, but people who, for whatever reason, are regularly using the call for an ambulance and they don't need it. Presumably, persistent users, and you may have said this, but I maybe didn't get it because you were facing away, persistent people who do that, are you able to basically refuse an ambulance and make sure that they're put towards a doctor or somewhere else?
No, it's not about refusing access to. no, but you're right. I think, but usually the route to solve the problem isn't to do with the ambulance. It's like, have they got the right support if they're there's a mental health issue and things like that, and so that's why the relationship with the acute, the primary care and YAS is joined up mainly through things like A&E delivery boards, where if in a certain area has a particular high concentration, then YAS quite right will say, well, what are the other partners in the system doing to alleviate that?
I think what I was trying to ask as well was, when that phone call is made, the person answering the call will presumably be able to see this is person X who's regularly calling us and try and divert to appropriate people. Is that right?
No, that's not. When we take a 999 call, then the non-clinicians will take the call. So we wouldn't expect a non-clinician to make a decision whether or not to send an ambulance or not. Default position that we would send. We do have flags on the system that would allow us to identify certain situations. So maybe main one's like a violent situation. So it would flag up that in this address, like, take care because this patient has been previously violent. We do have a frequent callers team, which is a team that sit down and they review, when we do have like certain care homes or certain individuals, they will get that information and they'll work with other partners to put a care package around and develop that in order to prevent that individual having to call the ambulance on regular occasions. And that's successful. That's been funded through commissioners as well.
But I think the main point is it's done as a follow-up, not at the start of the process.
Thank you.
Yeah, you mentioned the development of a number of pathways which might mean you can avoid admission to A&E or hospital generally. How are those being implemented? Do you actually see a reduction in the number of patients who end up in A&E or hospital because you've intervened and assisted them in some other way, more appropriate way?
So internally we have a specific team that looks after clinical pathways. So they've got all the experience in terms of how to develop a pathway with partners, make sure there's consistency in terms of having pathways. Not always, they're not always the same because of the services that are available in different areas in terms of how they're commissioned, but we try and get our pathways aligned as much as possible. And yes, they are successful and they are monitored in terms of how often we use them. And we also monitor where we think a pathway should be, so staff will put, I would have kept this patient at home if the pathway was open a bit longer, in this particular time window. So there are opportunities there to try and keep developing and have some evidence base moving forward.
So is that approach likely to lead to perhaps a change in commissioning in terms of the focus away from, to an extent anyway, from A&E to solutions in the community?
Yes, I think that's definitely the direction of travel. I think it's difficult to have a direct correlation between ambulance activity and attendance at A&E, but certainly in terms of what for example, the Kirkley CCGs will be investing in, will be in primary medical services and community services, and to make sure that there's an appropriate level of support out there that does then rely or reduce the reliance on attending A&E, because that's you think that's the only way you can access services, and then that will translate into our relationship with the house as well.
And just one other question, it's a bit anecdotal, it's to do with my perception that there are a higher level of roadworks over the last 6 to 12 months locally. Do you pick up on something like that, and does that have an effect on the ability for you to deliver the service?
It will put additional pressure on us, but obviously if it's an emergency call, then we can use our exemption so we can get through these congested areas a lot quicker, so that would have probably minimal impact on those response times overall.
Sorry, just one more question. In terms of the changes of the government, in terms of the changes that the government made, where how normal traffic car users respond or move away onto curbs whilst there's a 99 whilst there's a fire engine or an ambulance come over. I think that the rule has changed where they're not allowed to go onto the pavements and things. Has that impacted in the way that you've been when you've had to respond to, you know, getting through traffic and things like that as well? Not just obviously the work that's been done, but obviously the way that the rules have changed as well.
Well, actually, the changes to drive training has changed because I suppose when me and Nick were on the road many years ago, we'd be, if a red light was on, would we try to make as much progress as possible. Our drivers are now told, or they are drivers and clinicians at the same time, they are told to slow down and just let the lights change to green because it's quicker to do it that way rather than wait for cars to try to pull out your way. And by the time you got to the stop line, the lights have changed anyway, so it does make more sense to actually just slow down, turn your sirens off and wait for lights to go green, because obviously you're not allowed to cross a stop line if you're a normal civilian. Okay.
Just in the line of that question, the new smart motorways without the hard shoulder, having been caught up in a major traffic jam only last year, just off as I got on the motorway here, poor ambulances were trying to get through and it was mayhem. I just wondered if your reps, unions have flagged up with the government that maybe these smart motorways aren't quite so fit for purpose when it comes to health and safety.
Yeah, it's a little bit political, that one, isn't it? Yeah, unfortunately, I don't have to drive that much on to emergency calls on the M62 at the moment, but yeah, I'm sure it has an effect at certain times, but I don't know, I'm sure there'll be some sort of conversation taking place, whether it's the right thing or not, based on scientific evaluation. That's all I'd like to say on that.
Is there any further comments or questions? Okay, can I thank you for attending today and doing a very informative Q&A as well as your presentation. Can I recommend that we acknowledge the report and in future, whenever that is, that we get you back, we have figures on the use of private ambulances, and also we include response times for North Kirklees to be included in any sort of progress reports or any updates that you make available to the panel. Any more?
Yeah, thank you. Thank you.
Thank you for attending.
Just got the work programme now.
Yeah. Are you pausing it?
I've just gone straight on.
Okay, can we move on to the next agenda item, which is the work programme. Let's go through that. Shall we just go?
Yeah. It's just really to draw attention to the outline agenda plan, which I think I left on everyone's seat. It was just really to give you clarification in terms of what we've got coming up over the next sort of few months. And one thing just to sort of flag really is that normally towards the end of the municipal year, usually in the April meeting, we have an annual presentation by CQC. At the moment that still hasn't been confirmed, predominantly because we know of a number of issues that we think may have to come to the panel, and my concern is that CQC's presentation generally takes up virtually a whole meeting, so there might be a question mark over whether it's feasible to include them this year. As you can see, we've got a potential item on the proposed merger of CCGs. That's still to be confirmed, but if that were to happen, then I think it would be important for the panel to have sight of that and obviously a discussion on that. And we've also got another issue, I think you've got the details, it's to do with therapy units, isn't it, that potentially may be taking place across West Yorkshire. Councillor Zaman's having a briefing, funnily enough, early on this afternoon, to get a little bit more of understanding about what the impact of these proposals will be for Kirklees. And I think there may well be a move to bring that to panel, so you have sight in terms of those proposals, and you might have to consider whether you think it's a significant change for residents in Kirklees. So we're kind of like left a bit of a gap, if that makes sense, to just in case some of these do come through. So we've got the capacity to deal with it. So I didn't know if members have a sort of particular concern about whether or not you really do want to have CQC here. If you do, obviously we can do that, but it could potentially mean that we could lead to quite a long meeting unless you feel you want to have an additional meeting.
Sorry, I was just saying, not with all the my recommendation is not whilst we've got all the open issues still going on, because we'll still have the questions and the response will just be we're still looking into it. I'd rather have all the answers, or when they come to us, be prepared to at least give us the answers, not just say, well, we're still, you know, trying to find this information out. So give them enough time to be able to have those answers ready for us.
My memory is that there was one element of the CQC presentation that didn't take place last year. I'm not sure if that was right. Yeah, one area wasn't presented, I don't think, from memory. I just wondered whether, you know, whether it'd be useful to pick up on that area, if possible.
I can check on that. You're right, there was, I can't remember who it was now, but it was one area. I certainly can check up on that, and it may be that, I mean, we could still potentially slot them in, but I think my bigger concern was that some of these other issues that we still haven't resolved, it may sort of cause a bit of pressure in terms of that particular meeting, because you can see in terms of February and March, I think we're already, you know, I think two issues tend to be about as much as I think we can do with a panel. So it's just really just sort of seeking your views, and if you're okay, maybe potentially deferring CQC and maybe looking at maybe next municipal year, maybe the early part, we could do it that way.
I would agree that we do defer them on and have them early part of next, you know, the next sort of municipal year, and more so that they come back with like concrete sort of information, that we're not sending them away to get more information, and particularly the outstanding item that has been suggested, if we can include that in that.
And the other thing I wondered about is that there are possibly one or two issues that might have come out of things we've already done, that I don't know whether we have an opportunity to discuss, whether it's something that might have come out of the Locala visit or whatever, whether there could be some time allocated to just finalise things like that.
Yeah, I mean, what we traditionally tend to do is have a sort of what I call an annual review of the work programme, to start thinking about what items, for example, that we either haven't covered or other items that we still feel we want to look into in more detail, so we can start populating the work programme, obviously going forward. So certainly in terms of the April meeting, for example, that would be something that we could do, and in fact we would normally look to do that.
Is there anything else on the work programme that anybody wants to suggest? Or maybe even if there's any new items that you'd like to be considered for next year, if you put your thoughts into Richard.
I'll certainly send you an email in, because probably we spoke about, yes, covering the 111 service, and I think probably we could have a further look into the responses in terms of that, and that'd be good for the new year. And perhaps not the closures, but the restrictions at hospitals over the last couple of months because of the influenza and everything that's gone on. So how that's affected staff and how that's affected the performance itself.
Is that the winter pressures you're talking about?
Yeah, so we had the winter pressures up a few months ago, and obviously what's happened over the last couple of months. How that
all right. So the impact of winter pressures, because we'll end up with that again on the agenda again. You know, because we are sort of wanting to monitor that quite closely, particularly with the downgrading of certain services, and reconfiguration of some of the services.
I mean, to be honest, what we have done in the past, we used to get regular updates during the winter period from both acute trusts, and I think we can probably touch base and just, even if it's just a written update, I can get that and obviously circulate that to members.
Okay, thank you for that. If there's no further comments on that or any other questions, we come to close the meeting, and the date of the next meeting is 25th of February. I'd like to thank you all for your contribution and your attendance this morning, and we close the meeting.